Okay. Okay. Let's go. So same, you need to go for introduction. Then you will go for, when you come into the station, you will see few things. The depressed patient will look down. Means this is can you can get an idea that this station would be what. For example, if patient look down and or when you just introduce yourself, for example, sometimes it's very difficult, sometimes it's possible that you can guess from the patient that what station would be. When you get into the station and you say, hello, my name is Dr. B, may I confirm your name and age, please? So you will see a patient talk to you and look down, okay, and the withdrawal body language he's not using. That means this is depressed patient, means this station will more likely goes to depression. And for psychosis patient, what station has been counter most of my colleagues or most of my friends whom I know, they said the patient was irritable, not even worried, but irritable means the patient was even walking. The patient was like, he means not, patient was restless. For example, he was sitting, but he was like shivering, he was moving around. He said like that. And I also find once I had a station. So this would be like that. The patient will be irritable, not sitting well in one place, or maybe the patient is moving around in the room, or if he's sitting or she's sitting, she's like shivering, something like that. An unusual moment you will find in a patient. So that means this that person indicate like this patient might be goes to psychosis or has psychotic problem and station goes to psychosis. Next is many patients, she will be excited. When you talk to her, hello, my name is, may I confirm, she will be very loud. Her volume will be very high. For example, she will say, yeah, my name is Vivian. I am very happy person or anything she will explain you. I'm 32 years old. I mean, she will use a extraordinary activity like she will show you a lot of happiness from her volume and also from the body language. Okay, she will use her hands. Oh, I'm very happy. I'm excited to be. I always excited. Or my name is blah blah. My age is this. So from body language you can understand. So the money patient. Then other is anxiety. Anxiety is usually normally responds to you, and she can understand everything what's going on around her. Next is a self-harm. Self-harm always come with the depressed, but sometimes, as I said, you can have the patient overdose, which is relevant to toxicology. Anyway, we will come up to this station later. Okay, so depressed patient, first you introduce yourself. When you get to know the patient name and age, she will look down and she will say, yes, my name is Chloe, I'm 36. Then when you will, first you need to make her calm, like establish a good environment for her, and also you need to explain the purpose of meeting. So for example, you say, I have been told that you came to the hospital. That's what I said. These are the communication skills, show you how you communicate with the patient, how you start the station. This is very important. So you can start with different ways. Everyone have different ways to start it. So, but I just added what I think. I have been told that you came to the hospital because one of your friend worried about your mental health. Or you can say your daughter is worried about your mental health, or your husband, etc. So this is for depressed patient. If you found a psychosis patient, you say, I have been informed that you are worrying about something, or worrying about your safety at home, okay, etc., or safety at your work. Is that correct? Means this is a way you can start the station. Mani, what has brought you here today? Just simply say what has brought you today here, or what has brought you here today. Anxiety, the same way. But the self-harm, I have separate table. I will show you later. Okay, so what else? She said you have to empathy. I'm really sorry to hear that. And you go for, could you tell me a little bit about how you've been feeling? Here, now from here, I'm going to focus on depression station, okay? Keep in your mind. These, I already written these stations separately. I will show you how we take the history in psychosis. I have one more slide for that. I just put these 4 in because this is the beginning, so I just put it. So for what you have to focus now, patient will look down, you found this is depressed patient, you will go for, I have been told that you came to hospital because one of your friend worried about your mental health, then you will go empathy. I'm sorry to hear that. Then you will go for could you please tell me a little bit how you've been feeling? This is not for every station, but in depression, very, very common to say, could you please tell me a little bit more about how you've been feeling? How have you been feeling recently? Patient will say, I am feeling bad. Okay. If the psychosis patient, maybe this is also for psychosis, is really stressed and worried, I'm feeling absolutely great, fantastic in mania patient. Okay. And excuse me. Yeah. And I'm just struggling with the anxiety. So anxiety patient will answer you that. So after that, after you find that, then you will go for a connector, like say, okay, Miss Chloe, I have to ask you a few more questions. Would that be okay for you to better understand your mental status? This sentence you have to add by yourself. Okay. Then you go for depression question. So once you got the station is depression, so you need to start with the depression question first, instead of psychosis or self-harm. So if you found the station as depression, then you will go for how long that have you have been going for, how long have you been feeling that way? Okay. Is there anything particularly going on recently? So patient might say, yeah, I'm very sad because I lost my job. Maybe she said about her job. I really like that job. Maybe she will explain you, my friend left me. I broke up. Several things she will tell you. There are many reasons behind it. So is there anything particularly going on recently? Maybe she will tell, in this question, she will tell you that what has happened, why she is depressed. Maybe because she lost a job. Maybe she lost someone whom she was loving, or she broke up in a relationship, or she is sad about other activities in daily living. So this question can give you idea what was the cause of her depression. Another, I guess there is a lot going. Once you got the answer, then you use a connector, a connective sentence. I guess there is a lot going on. Have you been able to do anything that you enjoy? So this is also a question relevant to depression. Have you been able to do anything that you enjoy before? Or are you able to enjoy the things that like before? So keep in your mind, when you ask a question, try to use the connector. Don't go, are you enjoying the things as like before? Not jump up. Better to, in psychiatry, they also test your communication skills. So better to use the connective sentences that to make everything clear. One more thing I want to tell you, which is very, very common question. When you will go, I just stop it here first, okay? When you go inside in the station, you will find examiner. Examiner have 2 things in the hand. One is iPad, okay, tablet, or the examiner will have the book or the paper. So the Mrcem always give them a specific chart, okay? So what question you are going to ask, they will give you the score according to that chart, okay? For example, if they mention the depression and they mention the question, so you will get a score on the basis of that question, and they will tick it. For example, You ask the depression question, they will mark it. Okay, one is score for that, this question, another score. So this is how the Mrcem made everything for the examiner. So try to use a good communication skills, not only in the psychiatry station, in all stations. I guess there is a lot going on. Have you been, are you able to enjoy the things as like before? So she will say yes or no. If depressed patient, she will say no. Okay, sleeping pattern, you need to ask her about, have you been sleeping? Or you can ask her, how's your sleep? As long going on, is a lot going on around you, have you managed to look after yourself? Because depression patients usually doesn't look after themselves because they think like that, they lost everything. Okay, they have very low moods, so usually they don't. Eating habit, how's your appetite? Or have you been eating? Like this kind of question you can ask a patient. And also substance use. Substance use is a very, very important question in depression. So you need to ask this question here. Sometimes when people are dealing with such situation as like you, they try drugs or alcohol in a way of coping. Is that something you tried? Okay, listen to me, guys. Don't need to exactly follow what is written here. You can create your own sentence. There are different ways to communicate with the patient. So if you think that this sentence is okay, you can use it. Or you can create the simple way, the one you like. Okay. Once you ask the depression question, then you know that the depressed patient likely have the self-harm, okay? Risk of self-harm. So the next you need to ask a question about self-harm, then psychosis, then cognition. Okay. Once you ask this question, then you come up to self-harm. So you need to ask things that have felt that bad you have been thought try to harming yourself, or have you ever tried to harm yourself? Okay. Or you can say there's a lot going on you. So sometimes some people try to harming themselves. Is that you did? Is that in your case? Like you can ask this way question. Or have you tried to harm or others, harm yourself? Okay, you can ask this question this way. Then if she say yes, so what is that thought about doing, or what were you trying to do? Maybe patient say I was planning to take the paracetamol. Maybe I was planning to take aspirin overdose, maybe the medication. Maybe she was trying to do another harmful activities, or to jump from the flat or anything what she else said she can tell you. Have you written something or informed anyone before harming? So when patients say yes, then you go for this question. If patients say no, don't go for further question, just stop it, okay? And then you go, the last question you will ask, have you thought about hurting or harming anyone else at any point? About others, okay? So what happened usually, depression patient likely harming themselves. Not everyone, but if you find the station is that, so this, I will tell you how you manage if the patient has self-harm. Then you go for psychosis. So here, one or two questions. Have you been ever worried that someone interrupt your thoughts? Then if she said no, then you go for, okay, sometimes people feeling in that way you are now, they might hear or see something abnormal, which cannot be explained. Have you experienced something? This is a connector sentence. Sometimes people feeling that way, but you can ask another way. Have you experienced something which other people doesn't see or they hear? Have you experienced such kind of things? Or you can say, did you hear any voices which other people cannot hear or cannot say? You can also ask like this way. Or here I mentioned already, do you see or hear something abnormal which cannot be explained? So you can ask different ways. So one or two questions from psychosis if the depression station is up. Do you know where are we now? What time is it? Who am I? You can add it. And the last one is, what do you think is wrong with you? So guys, these all questions are relevant to mental state examination. Okay. what I want to say is all questions are relevant to mental state examination. I would say, 1 second, I haven't mentioned here. Explore the patient. So, mental state examination. So, guys, what I mean by mental state examination? These are the questions. I want to mention that. So, what's happened sometimes? Candidate got confused when they mentioned the scenario, a case, and they say task, assess the mental state examination, or do the mental state examination and take a history. So people get confused. What mean by mental state examination? This is just one. Okay, clear so far about mental state examination, guys? Yeah. Okay, so these all questions are relevant to mental state. And the same, this questionnaire has been using by psychiatric, the doctors which are working in psychiatry or their specialty is psychiatry. Okay, so then you will go for the further questioning that I need to ask you a few more questions. Is that okay? Did you have any mental or psychological problem before? Any past medical history, surgical history? Where do you live? Whom do you live with? What do you do? If you already ask about the substance used, you don't need to ask these two questions, okay? Closing consultation. Do you have any question? Okay, done. After that, then you have to present mental state examination finding to the examiner. So this is very, very critical stage. Once you take short history and do the mental state examination, after this examination, you need to go for the present finding to examiner. So the important in psychiatry station is two things, only two things. One is the mental state examination, and other is presenting finding to the examiner. These two stages are very, very critical. Your most score come from these two places. They don't care about your clinical decision. Even you don't tell the clinical decision, or you forget to tell, or the station is over at the mental state examination, you will still get the highest score. So you don't have to worry, because in the task they mention you take a history and do the assess the mental state of the patient, or do the mental state examination, take a history, and present your finding to the examiner. So you did three things. History is very short. You say you are going to ask only past medical, these past psychiatric history, past medical history, family history, social, very few questions, and then close consultation. So the important are the only mental state examination and the finding to explain the examiner. So these are very important. So let's come up to, I write down already here to make it easier for you, that you can just verbalize it, or you can just memorize. It's very, very easy and very simple. So today you will go to, once you finish your consultation, then you will go to turn to the examiner, look at the examiner. Today I assess Colin Russell, a 38-year-old male presenting with low mood, okay? Because the depressed patient always present low mood, and if he has suicidal ideation, you also need to mention that. In suicidal ideation on the background of significant social stress. Social stress means maybe he dropped out from his work, okay? He lost his job, or other problems could be, so you can mention. For the last couple of days, he's struggling with this suicidal ideation, trying to harm himself with paracetamol. If he said, I was trying to take it. If he said another things, you need to mention that, harm himself with knife or any other things you can mention, whatever the patient say to you. He says that his family and friends will be better without him. So guilt and worthless is very, very common in depressed patient. So on examination, then you would mention, on examination, he appears sad and cheerful, if he is cheerful, with poor eye contact, with the evidence of psychomotor retardation. Then speech, you will comment on the speech. Colin speaks slow and monotonous, or that means the tone is toneless speech, okay? Or we can say the variation of tone is there is a variation in his tone. So the lack of variation, sorry, means only one straightforward, like sad all the way in communication. So lack of variation in his tone, that means monotonous. Okay, mood and effect, and he described his mood as low with evidence of an adynia, poor concentration, and early morning waking. So the thought and perception you will, if he has, so you need to say, Colin described moods, congruent helplessness and guilt. He denied any perceptual abnormalities. For example, when you ask him, do you see or hear anything? So these are the perceptual abnormalities. So if he denies, so you need to mention he denied. Cognition, Colin was oriented to time, place, and person. Insight, judgment. Colin demonstrated partial insight, but he doesn't believe that his cognition of the guilt and helplessness could be related to his mental heart disorder, because as I said earlier, the depressed patient usually represent the guilt and also the worthlessness. Risk, in terms of risk, Colin repeated ongoing suicidal ideation and planning to take paracetamol overdose. He denied any thought or intent from other. So it's not necessarily that you pick up everything, but whatever you can pick up from here, what I put in the finding. So this is very important. Usually the patient presents these findings. So you can write down in your paper if you have time to, and also memorize that's what has been written, because when you take the history, you also need to speak very fast. So you need to pick up a few points, not everything. If you think you are good enough, you can pick up entirely, because it will give you the, as I said earlier, that the examiner have a chart and they give the score according. So on examination, examiner will think, did you comment on appears? Did you comment on patient behavior? Did you comment on speech? Did you comment on the mood and effect of the patient? Did you comment on thought and perception? Did you comment on cognition? Did you comment on insight and judgment? If you miss any one of them, you will lose one score. So this is what I want to say. In psychiatry, in every station usually, but in psychiatry, each everything is very important. The most important thing, I said 2 important points. One is the present finding to examiner, another mental state examiner. Rest you think forget 1, 2 point, no problem. These are the most important. So you need to memorize very well these 2 parts of the psychiatric history. And also I clearly mentioned and highlighted very well appears, what you need to comment on appearing, what you need to comment on behavior, what you have to comment on speech. So it all depends on all stations. You need to follow that. Okay, so this is about the complaints. If you have time, you also need to go for the management plan. So usually they don't ask you to comment on management plan, but if you give that would be great. So let's come up to the management plan. So sorry. Okay, so what is the management plan for this guys, for depression patient? Anyone? I have slide for that, but I want to tell you, if a patient with the low risk, I will tell you there is a special score we're taking, but anyway, you just need to one thing. A patient present with the self-harm, that means high risk. This patient really need admission under the mental health service team, okay? You don't just need to comment, this patient is high risk and I need to admit this patient under the mental health service team. psychiatric assessment. Anyone can tell me what is psychiatric assessment, guys? What mean by psychiatric assessment, guys? Anyone can tell me?
The patient will be seen by psychiatrist.
Okay. Okay. So what a psychiatrist will do, actually, psychiatric will do the same mental state examination. We refer this patient to psychiatry due to a few reasons, because CBT, okay, cognitive behavioral therapy or counseling, is given by psychiatrists, not by the ED. That's why we refer this patient to them. Okay. Anyway, he's a low risk or the high risk. We will refer this patient to the psychiatric specialty for the treatment, for cognitive behavioral therapy or counseling, and also for the need admission or referral, what possible, or follow-up, because we cannot give this treatment to this patient from ED. So this is a job of psychiatry. Regarding assessments, the assessment is the same as we are doing in the ED, mental state examination. They will do the same. Okay. Once we did, they will.
So in both cases, we have to refer patient to the psychiatric team.
Yes, they both.
Either he's low risk
yes.
or moderate.
Yeah, in both situations, we need to refer, because the cognitive behavioral therapy also need to given by them or given by the general practitioner, which who has skills on that. Not every doctor. Clear? Both cases need the mental health service team intervention. We cannot do it, because if it's low risk, he needs CBT, the cognitive behavioral therapy or counseling. Counsel we can do, but it will not really successful. So the moderate or high risk, he need admission. Okay, the high risk and moderate risk, always a patient has the risk of self-harm or to others. We will come up to the management of depression later in the next slide. I will show you. Okay, so
Doctor.
Hello. Yes.
Yeah. To assess the sad person score before commenting on low risk or high risk.
Sad person score coming up to the this is self-harm station. Okay. Self-harm station, okay. Not in the depression. Okay. Let's come up to psychosis. So psychosis is the same way. This is another slide. I made it. I make separation because I don't want you guys get confused. Maybe my teaching way is a little bit complex to get you understand, but overall, when you go with by yourself, maybe a lot easier for you. Anyway, so same introduction. So, because here I mentioned this about psychosis. Okay, so station is psychosis. You will say the patient will be irritable or worried, then you will go for the next one. I have been informed that you are worrying about something, or you're worrying about your safety. Once you find the patient is, the station goes to psychosis, then directly go on this, explain the purpose of meeting the patient. I have been informed that you're worrying about something, or worrying about your safety. Guys, don't use how can I help you, okay? It doesn't make sense. Okay, in most of station in psychiatry, it doesn't make sense. Like, if patient is depressed, how can I help you? It doesn't make sense here. Okay, you need to create environment for the patient. You know, if this patient once you introduce, you found a depressed patient, then you need to support the patient, and you need to explain purpose of meeting. That patient should talk to you, communicate with you. If you ask, just get in and introduce and directly go to the open question, he or she will not respond to you. And this is not a good way of communication either. So you should be very careful. I have been informed that you're worrying about something. You're worrying about your safety at home. Is that correct? Okay, I'm really sorry to hear that. Can you please tell me a little about how you've been feeling? Okay. Because psychosis or depression, but thing you need to ask the feeling. Then patient will say, it's really stressed or worried. I'm really stressed at the moment. I'm really worried about something. Maybe patient will show you, ask you, oh, look at the door, there is something. Maybe if patient is saying something, it means hallucination, okay? Perceptual abnormalities if patient has it. So it's two kind of patient you can have in psychiatric station. One, maybe patient have perceptual abnormalities. Patient will say, I see something, there is near the door, maybe the visual hallucination. Maybe the patient have thought problem. I think somebody getting thought in my mind. I'm feeling like somebody inserting thought or taking away thought. I'm hearing some voices. So you can see, you can find the patient maybe explain to you about what he's worrying or what he's feeling. Okay, thought content possession abnormality. So then if the patient say, I'm worrying, I am stressing out some things, and then you ask a question, okay, what is worrying you? Patient may say, I knew they want to kill me. Maybe he will say, I will be killed by someone. Okay, so then you will go further question. Who's that? Who are they? Maybe patient say, my worker, my roommate, my relative, my husband, my sister, anything. Okay, then you'll go for further question. How do you know he or they want to, they want to kill you or harm you? Patient might say they want to kidnap me or they are trying to poison me. Maybe he or she will say like that. Okay, so once you find that, then you further elaborate with the question. How did you find that they want to poison you? From question to question, close consultation. Once you find, ask the patient say, I'm hearing the voices. Then you will say, okay, could you please tell me whose is this voice? Who are they? Okay, patient say, I hear the voice, I don't know. Maybe patient say, oh, I hear the voice of my husband. Okay, then you say, what he's saying, what she's saying, or what your friend are saying to you. Okay, this way you can elaborate further. Or if the patient says someone want to kill me, then you ask, who are they? Who is that? Why do you think so he or she harm you? So you can ask further question that. Okay. Another is you can ask, is there any reason you think they might want to hurt you? You can ask further question. And then you come up to thought insertion or withdrawal. Do you feel that someone put thought in your head or taking thought from you? Sometimes people feel that either thought been broadcasting louder, like everyone in the room can hear them. You can add this one, okay? Then you come up to perceptual abnormality. These all are relevant to psychosis question, guys. That's why I mentioned in the red that this is an important topic. The rest of them are subtopics. So, do you see or hear something abnormal which cannot be explained? Maybe patients say yes, what they say, what they talk to you. If you already ask about this in first questioning here in thought content, so you can skip that one because you don't need to repeat the same question. Okay, what is that? What they talk to you, what they say to you. Okay, maybe patients say, they say to her, her name is maybe Liz, and she said, Liz is a terrible, Liz is a nasty, she's a bad person. Maybe he or she will explain to you like that. Okay. Is that to directly talk to you? How many people or persons talk to you? Do you know him or her? The same I already said before. So this is the way you can ask about this question if the patient. So it all depends what kind of patient you're having. Is a patient has perceptual abnormalities or there is another like thought insertion or withdrawn? Okay, so relevant to that. So if you found it perceptual, you need to go ask a question further from first open question, then close consultation. After a psychosis patient, the same way you will go for depression. Okay, with all going on, again, connector, with all going on, have you felt low or depressed at all? With everything that's been going on, have you ever tried to harm yourself? Okay. Or with everything that's been going on, have you ever tried to, sorry, this here doesn't need to be. Okay. Have you ever had a thought to harm others? So cognition, then insight and judgment. What do you think? What wrong with you? Do you think you need a treatment or like this? So you need to ask her the question. Okay, so it's clear so far, guys. I made it very simple now because this is just psychosis question, and then the very short questioning about the depression, self-harm, and cognition. I think very, very clear picture here, right? Okay, then the same you will go for past psychiatric history, past medical history, family history, social history. Okay, close consultation. Then again, you will present finding to the examiner. So background of psychosis, or he present to emergency department, blah, 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 you need to say, and then you appear in behavior, and you will say he appears distressed and anxious. However, he engaged well during the assessment. He was monotonous at time, mood and effect in terms of mood. He appears stressed and worried. He denied any thought of self-harm and other, etc. Thought and perception. Colin described paranoid, psychiatry delusion of belief. That means which is unfounded. Okay, unfounded, which now as his support worker want to poison. Colin has reported auditory hallucination if he has or she has. Cognition, Colin was oriented time to place and insight, and appears lack insight into her substance being related to deterioration. And then you will go for the treatments if required. If they ask you to clinical decision reasoning, then you also tell the treatment for that. So what's the treatment for psychosis patient, guys? They also need counseling and cognitive behavioral therapy. So you need admission or referral to mental health service. Okay. Okay. So yeah, you cannot treat this patient. You cannot start directly to the antipsychotic medication or antidepressant. Okay, so let's come up. So that's why what I said, the Mrcem usually focus on two things on psychiatry. One is the mental state examination. Okay. Second is your finding, how you present your finding to examiner. Did you present what you have found? So this is very important. About management, most of cases need the admission under the mental health service team or the referral. Okay, so mania patient, the same way. Introduce yourself, and you will see the patient will be looks excited. And sorry. And the extraordinary happiness would have brought you today. Why do you come to the hospital? And she will explain you. Maybe she will say, no, I don't have no any problem, but my husband just bring me here. Usually the patient will answer you like that because she thinks like that she's fine, she's a great person. So, or he, so usually they give you answer like that. My husband brought me here and I don't know why she or why he brought me here. So she will say like that. Okay, could you tell me a little more about how you've been feeling? She will say, I was feeling absolutely great, fantastic. So this is all. And then you will go for the press question. Okay, okay, Miss Chloe, I have a few more questions. Would that be okay? And then you go for it. Okay, how would you say feeling normally? She said, I always feel great. I'm always fine. Maybe she will say like that. Sleep pattern. How have you been sleeping recently? She said, yeah, I little bit disturbed in sleep, but overall I'm great. I'm feeling great because I have a lot of work to do. I'm great personality. Maybe she will think I have a contact with the NASA. and something she will talk like which is really not exist. Okay. How's your appetite? How have been eating? So after this question, you would go for psychosis the same way, perceptual abnormalities, and then self-harm, then cognition, judgment inside. Do you think what you're feeling? So this is very important here inside of judgment, because you cannot ask, do you need a treatment? No, directly, but you can ask like this way. Do you think what you're feeling or saying it's not correct? So if she said, no, it's right, I'm feeling great, that means she doesn't have insight. Okay. Do you think you need a treatment? What you're feeling, it's not normal. She will deny it. Okay. Next is past medical psychiatric history, medical history, the same way. Then you will go for today I assessed blah blah blah, examination, she appeared blah blah, and kept animated, frequent. And also the speech, her speech was rapid at time, increased volume, the same about perception, cognition, and again insight and judgment. So overall, she also need a mental health team. Okay. So if even you don't, if you want to give the treatment plan on your own, so what you will say, guys? So what's the treatment for mania, guys? Anyone can tell me? Anyone can tell me the treatment?
I think it's the
Admission
same.
also.
All psychiatric cases should be referred for a psychiatrist.
Yeah, that is correct. But you also need to, in case you need to, I think mania patient can be managed now in the ED also. It's not exactly necessary for psychiatry, but if you mention that would be great. So what's the treatment usually we prescribe the mania patient? Any medication, if you remember?
Lithium.
Yeah, that is it's been avoided now, but it was. So the oral antipsychotic medication we give to haloperidol or olanzapine, quetiapine, so these all medication we give. But for the purpose of exam, better to say the psychiatric mental health service team, admission under the mental health service team. Okay. Okay, so next station is anxiety station. So anxiety station is not very common, but you can have it. Anxiety patient always responds to normally. You will not have any problem. And the same question, what has brought you here today? I'm just struggling with anxiety. I'm sorry to hear that. Then you will ask, what mean by that? Could you tell me a little bit how you've been feeling? The patient will say, my heart is racing, sometimes feel sweaty. Then you will go for anxiety question. The problem is anxiety patient is that most of people have the panic disorder. Okay. So you will ask a few questions like, how long that have been going for? Is there anything particular? Maybe she will mention, yeah, there was a car accident. Okay, because anxiety is always due to some incident, right? When patient these thoughts came in mind, when patient think about those things, bad thing or which has been done in the past, or they have recently encountered any serious incident, so patient likely to suffer with anxiety. So maybe patients say, yeah, my friend was with me and they had a car accident, she died in front of me, and I can tolerate. After that, I'm feeling that whenever I think about that. Okay, then you'll go for anything particular you worry about. Is there any situation that cause you to more worried? Yeah, patient might say, yeah, whenever I find my husband go outside, I always worry. Maybe I worry that maybe he will have a car accident, because these are the frequent thought to come in her mind. So frequent worrying. Anxiety patient always worry about the same incident, about if has been encountered in the life. Anyone, for example, if a car accident, if someone who loves her or children or any family member go outside to drive a car, she always worry. Maybe she will worry about them. Maybe she will have a car accident. So she, in real time and practical time, maybe she always try to call him or her. Oh, are you okay? Are you arrived safely in the school? Okay. Are you arrived at work safely? How are you? Like frequent asking question. Even there is nothing to worry, right? So relieving factor, is there anything that help you to calm down? Maybe she will say, yeah, whenever I watch movie or whenever I do watch some comedy to divert my mind, okay, watch movies, or when I play games, it's divert my mind, I don't feel that. Okay, then you go for panic attack history, which is very common in anxiety patient. Have you ever had a panic attack? Okay, you can ask her. Okay, impact on daily living. How has it been impacting your daily activity, all of these anxiety issues? Yeah, it's really affecting my relationship with my children, my family. They always think something wrong with me, why I'm asking them all the time. So this can be possible. Sleeping pattern, have you been sleeping? How's your sleep? Maybe she said, no, not really. There's a lot going around you. Have you managed to look after yourself? So yeah, some of them can look after, some of them no. Okay, the same as usual, depressed question, self-harm question, substance use. Substance use very common in an anxiety patient. So you can ask them, sometimes when people dealing with such situation, they try a drug or alcohol in a way of coping. Is that something you tried? Maybe she say yes or no in psychosis. Inside judgment, which is usually coming up normal in this patient. Okay. So in the end, there are two ways. Then you will present finding to, if they ask you to present finding to the examiner, then you present finding to the examiner. Okay. So most commonly present finding, I had never heard about like to management plan, but it can be. If they ask you, don't ask you present finding to examiner, then you go for a management plan. Okay, so what is the management plan for the anxiety patient, guys?
Anti-anxiety.
Usually, this patient can be discharged from the ED safely. Normally, patient, if doesn't have any self-harm or any, because this patient is not very complicated. I mean, he or she will not have this a lot problem. She just need a diversion to cope with the problem which is what's going on around her. So she requires self-help. Self-help, what we do, we give a printed leaflet to the patient, and there are different strategies to cope with this condition. And I will share in the group also this link, and you can find it. So most likely she will require the self-help. We give a printed leaflet where it's written, first of all, she will think why she's having this problem. Then she will make a plan how to cope with that. She need to recognize why she's having problem, why not others. Like this kind of leaflet we give to this patient. And also there's another way, computer program. So computer program have a special program where she can watch it and she can treat herself by herself. I mean, to follow the strategy and to avoid this old problem. So this can be safely discharged. Anyway, if you think you cannot, you can say she will be admitted under the mental health chain. But overall, I will send you the link in the group, and you can check out how to treat this patient. So that's what I say. What I want to say, so she can take a self-help, and also there is computer programs which can give her, she can watch around 5 to 4 sessions per week. Okay. If she doesn't progress, then we have psychological therapy. Psychological therapy, which is given by the psychiatrist, called CBT, cognition behavioral therapy. There are the session around few sessions in a 3 or 4 month. Okay, it depends. And also sometimes we give a medication, the antidepressant called serotonin reuptake inhibitor, SSRI. So This medication also in severe cases we recommend. But for the purpose of exam, you will not have a lot of time. So you can just say the admission under the mental health team. But if you have time, you can explain. There are different ways. One is you can just say, yeah, she will need a self-help. I will give her a printed leaflet for that. And also she require cognitive behavioral therapy, which will be done by the psychiatrist. So I will refer her to that. And so they will decide if it's severe case and maybe she will require medications. You just need to mention that, show the examiner that you know it, how to manage. Okay, so this is about the mania patient, anxiety. Okay, so the next is about self-harm. This is also a very common station, but in different ways usually come up with the toxicology, the overdose of the paracetamol or the medication. Usually this is stations like that, paracetamol or the aspirin or calcium channel blocker, or come up with the iron overdose. Previous exams commonly came up with the iron overdose. So the same way you need to establish the environment. I just want to have a brief, because this patient is risk harms, okay, self-harm station. So patient usually very calm and cool, and maybe she doesn't respond to you directly. So first you need to give her a nice environment that she feels safe. So you need to establish the environment, then explain the purpose of the meeting. I just want to have a brief chat to see what's been going on, so that we can work out to help you, and if possible to get out of this hospital. If the station indicates you to assess this patient, is this patient safe to discharge? So if relevant to that, better to go this way. Anything that said here today will be confidential unless I feel another person is potentially at risk, in case I would need to share some information. But if you don't say this all sentence, also okay. Just say anything you will tell us would be kept confidential, okay? Then you would go for the open question and explore the present complaint. Then go for the precipitant. Let's start. Can you tell me what happened? Okay. Maybe then she will start like, oh yeah, I took the paracetamol tablets. I had a fight. I had a problem with my friend. I was angry with my friend. That's why I take the paracetamol. Then you will go, why did you take these tablets? Or maybe you just say, before you go, maybe she will say, yeah, I came in a hospital and I want to go home. Then I want to go home and I'm okay. I just took the paracetamol dose. Then you ask her, why did you take them? Maybe patient will say, yeah, I took them because I was angry with my friend. I just take it. Then you will go for the intention, the quantity. Where did you take them? Okay, for quantity, and also the where you got them. So where did you get them, these medication, or where did you get this medication, or where did you get the medication from? Maybe she said, oh yeah, it was in the cupboard, or it was in my room and I found it. Okay, how much of the medication did you take? If the medication, but if it's the cut rest or the other cut marks, so do you have other cut? Do you have the marks in other area of your body? Where did you have the cut marks in like this? Why did you cut your wrist, or why did you harm yourself? You can create your own question. But usually, for the purpose of exam, if we check from last few years, I'm finding usually paracetamol or the iron overdose. These are very common station. So then you will go for, is it planned or impulsive? Did you take it to? Did you plan to take them, or did you plan it to cut your wrist? if it is the harming self with the knife or any other the sharpened equipment. Did you take these tablets impulsive, or that means without thinking? If the patient say to you that I take it just I was angry, then means this is not due she wants to suicide. Okay. So you need to know about without thinking, or did you write any suicide notes? If she said yes, that means she want to kill, harm herself, and that's intentional. Okay, precaution. What protective measure have you taken, like closing doors, going somewhere very remote? And then you go substance use. Did you harm yourself under the effect of alcohol, or did you take this medication with alcohol? Okay. Did you take these tablets with alcohol or any other recreational drugs? Have you ever carried self-harm in the past? Okay. If yes, what method of self-harm were involved in that time? So you can ask more questions. So one, first, the precipitant quantity and the location, the place where she got it, planned or impulsive, precaution, substance use, previous episode. So you will get a score according to this question. Even you ask one question, you will get the score. If you miss any one of them, you might lose your score. Then again, the same question like depressed and self-harm usually also have the depression. That's very, very common. So you can ask for depression question in psychosis. It doesn't require cognition in this station. Okay, the same way the past psychiatric history, family history, etc. And remember one very important thing. I want to come up with that. So, okay, for example, I want you should participate. Okay, I have to ask you a few questions. Please give me an answer. Look, the patient. You have a case, like I have a case. The patient brought into the ED with the paracetamol overdose, and all the investigation came up normal. But the patient would like to go home. Okay, and they didn't mention that what is the level, but they mentioned that your colleague wanted to give the N-acetylcysteine, but she refused. Okay. And they ask you to assess her and check it if she is safe to discharge. So now you see in this case, they say that she refused to take the antidote. Okay. So what you have to do in this case, what you will do in this case, guys, I need to ask you first question, then I want to see your answer, then I will come up to my answer. What you will do, guys, then?
Admit.
Capacity assessment.
Capacity assessment.
Mental health assessment.
Okay, you did a mental state examination, and she said she was angry with her friend, and she just took the medication. She wasn't playing it, right? That means she just take it. She wasn't playing it, right? You did the mental state examination, and her risk set person score you take it is low. Now, your colleague, they also mentioned in the case, your colleague want to give her neck N-acetylcysteine, but she refused to take it, and she just want to go home. So what you will do? She's low risk from
if she can capacity
Okay,
assessment, whether she can
I will check mental capacity and see if she's mentally capable to discharge.
does she has capacity to make decision or not?
Okay, very good. So you need to check the mental capacity, okay? But one thing I want to tell you, if the patient says she will harm herself, okay, again, or she has intention to harm others, in that case, you need to admit this patient even she wants to go home. Okay, So that is
Yeah.
what you, that is what the Mental Health Act, which is 1983. We have this act I have written in depression management plan, and I will show you. So you will say to that we have a special, the law called Mental Health Act. According to that, I have to admit you, and that would be compulsory admission. We'll come up to that. But overall, if she is a low risk, you check the mental capacity and she has it, and you counsel her that if you do not get this one, it will harm to your liver will be damaged, but still she refuses it, then you need to destroy this patient because she has the capacity. So this station is very complex and always come in the exam. So how to rule out the psychiatric assessment first, the psychiatric problem, you will use the set person score. When you have the case, for example, before you start a station, you will have the case outside of the door. You see the male. If male, that means 1 point. Okay, they will mention the age you need to check out. That means 1 point. If you see this is a girl and the age is not relevant, so 0 point. And when you come up inside and you found how's your mood, and she explained you that her mood is low, she recently found she is depressed, that means 2 points. Okay. And there is, for example, suicide ideation, if she has it, or she is, for example, planning to harm himself, that's mean high risk. I want to make it very short. Any patient who has plan of self-harm and also to harm herself in the future, she needs admission. Don't think too much about the set person score, just go for admission. Okay, why? Because of the Mental Health Act. Clear, guys? I want to make it very simple. Any patient who wants to harm him or herself, or he intend to harm others, go for admission, and that's compulsory according to Mental Health Act. Okay, ignore the set person score. Okay, if she doesn't have, then you need to little bit think about the set person, like you need to find out the score, what would be. So I have in management.
Can you come again? I couldn't understand you. I have internet interruption. Can you just repeat it again?
Okay. I want to say any patient who has a risk of self-harm means again going to harm him or herself, or he or she is going to harm others, and that this patient needs admission. According to Mental Health Act 1983, I have written this act in the next slide. I will show you. Okay. So any patient with any going to harm him or herself, admit this patient. Not here now. When you ask the question, are you going to harm yourself if I discharge you, or do you have any plan to harm others? We have this question in self-harm. So if she say yes, then she need admission. Even don't need to follow the set person's score. This admission is required due to the Mental Health Act. Okay. So if the patient deny harm to others or harm herself, then you go for set person score, and I'm sure that set person score will be low, and then you can destroy this patient. And if she or he has the mental capacity. Clear? It's not clear. I think it's very complex, right? Still not clear. Okay, so let's come up to next slide. I want to show you. I have written it. Okay. Next is alcohol. I made a slide for alcohol too, because I want you guys should make the difference. What question should be asked in psychosis stage? What question need to ask in depression? What question need to ask in anxiety, what question you need to ask in mania patient, because I'm finding that you guys are mixing all the question, which is even not relevant. Okay, you are going to your communication is going to be very, very simple, just like you. I would say even I give to 5 years old to memorize his old question, and he can even do better than us. So this is not a good way to run the station. So better to run the station professionally and use the connector to talk, communicate with the patient. That's why I put the different slides for each station, like for depression, separate, psychosis. Don't want you guys mix it. Okay, let's come up to the alcohol dependent station. The same way you introduce yourself. I just want to have a brief chat regarding established environment, regarding your alcohol intake. Is that okay with you? Screening tool we have. Okay. Even in the hospital, practical life, we use two kind of the score, cage or the audit C. So you can follow any one of them. Better go for the cage, which is very, very simple. Have you ever felt that you should cut down on your drinking? So you just start with the screening tool, and then so this can give you idea score over 2, so the problem drinking and need the admission under or the referral to alcoholic specialist. Okay, alcohol intake and impact question. So these are the questions. After you finish the screening tool, then you will go for this question. When did you first notice an increase in the amount of alcohol you were drinking? Then you will go for how often do you drink alcohol? How much do you drink on an average day? Have you ever tried to stop drinking before? Maybe say no, maybe say yes. If say yes, then what happened when you tried? Then you elaborate more close question. Sign of dependence. If you stop drinking, do you notice that you feel down, angry, anxious? If you stop drinking, do you get the shake, sweating, or feel sick, or notice any physical changes? Effect on your daily life? Is it affecting your daily activity? If yes, how it's affecting? Driving, do you currently driving? Because in the end, you need to inform the DVLA. What kind of vehicles do you drive? Alcohol-related crime. Have you ever committed a crime or had the police involved as a result of your drinking? Then depression again question. Psychosis the same way. Risk of harm question. That's it. Same way you go for these all questions, but this patient need, because you're communicating with the patient, so you need to give the plan for the management plan, but you don't need to present finding to examiner. So you'll just say, okay, I'm going to admit you under the alcoholic service, or I'm going to refer you to special alcohol services that will help you how to encounter, or they will help you to cut down your drink. Okay, so this is according to, so you just simply mentioned clinical decision is not a really big deal. The most important in this station is how you run the station. Do you really follow the screening tool or not? This is very important. The bulk of the score is coming from your screening tool about the history you're taking about alcohol. The management, you just quickly make it simple. Just say, I'm going to refer you to special alcoholic services. You need to cut down your drink, and you'll explain why do you need to cut down drink, because it can harm your liver. You can have liver problem later on. Just like a communication, what the complication of alcohol patient will have. Just explain that. That's it. If you have a lot of time. Okay, so this is a very simple station, but you need to be very familiar with the screening tool. Okay, so now we are in this and the depression. I also write down the management of the depression here. Okay, so clinical feature of depression is the feeling down, low mood, disturbed sleep, loss of energy, agitation, slow down, etc. These all you will get in the history. The NICE depression screening tool and classification, they give a PHQ-9 scale for that. But I don't think so. You need to go for it. I just put is if you have a lot of time, but I don't think so you will have time, but you should know about this scale. They use PHQ-9 scales to find out how severe is the depression. Less severe encompass the mild depression, defined as depression scoring less than 16 on the PMHQ scale. So the more severe is around 16. I think total is 29 or 30, probably. So you need to find overall for the purpose of exam is need the special mental health service team admission or referral. Okay, let's come up to Mental Health Act. It says allow compulsory admission of the people who have a mental disorder of the nature or degree that warrant assessment or the treatment in hospital and need to be admitted in interest of their own health or safety or for the protection of other people. In this, you need to use this act, okay? Patient present to you with the depression and he has the risk of self-harm, then need admission. If patient refused to you, go for Mental Health Act. According to it, need a compulsory admission, okay? The same for the risk of self-harm station. That's what was we discussing previous. That's why I say a patient present intend to harm others or harm him or herself again, admit this patient. Okay, so this is again a new piece of less severe depression. You need to go for self-help first line. Self-help first line I will put in the group. Overall, better to refer to mental health services because cognitive behavioral therapy, they will run it, not you. And also counseling. Okay. Psychosis, patient will hallucination, delusion, as we already discussed. Positive and negative facts. The mania, you can check it when you have free time. Generalized anxiety disorder and the risk of self-harm. Okay, so lastly, I want to show you this table. This is a patient health questionnaire 9, and you can see this is a lot of interest. This I just put it, so maybe you wondering what is it, so I just added so you can check out. Overall, you don't need for the examination, for the purpose of exam. Okay, guys, so we finish about the discussion about the psychiatric station and the importance about how to take the history or how to do a mental stat examination. Clear, guys? Any question here?
I just have a question that should I mention about confidentiality in all psychiatric stations?
I think it's not necessarily. As long you, as I said, the most important in mental state examination, patient even doesn't want to talk to you sometimes. So this is very important for risk of self-harm, okay? But not for other stations. You don't need to just skip because you see the already station is a little bit longer. You need to take history, then you need to go for the presenting complaint to examination, so examiner, and also maybe you're required to give a clinical decision. So it's already very long. So better is not avoid that. Just go start. But important is that you need to explain the purpose of meeting. Okay.
Okay. And
can we ask a forensic history, doctor? If the patient have any problem with the police?
Yeah.
That need to ask or no need?
Yeah, you can in risk of self-harm, yes, you need to ask in some station record. I forget to edit, yeah, forensic history maybe record, but not at all. The most important mental state examination and the presenting complaint. It's not required in mental state examination. There is no forensic history, but if you aid it in history taking, so aid it, you can aid this point, no problem. There's nothing about that. Yeah. Any other question?
Yes, Dr. I'm asking about mini-mental examination. If that is a common case in exam or not?
Common station where?
Mini-mental.
Which station, please? I couldn't get you. Could you please say it again? Pardon?
Mini-mental examination.
Mini mental examination. No. That's not really common. That's why I didn't aid it. That's not really common. The commonest station, as I said, the paracetamol. If two stations come up, if one station come up, psychosis or depression, very, very common, very common. But if two stations, they will aid itself on. Because this is very complex station. If you mention the Mental Health Act, this is also can get point, because they want to see you, how's your knowledge. Okay, Mental Act is very important in some point of, because these patients, if the risk of self-harm station comes to you, usually patient doesn't agree with the admission, you know. They will not agree with you about the admission. So you have two choices. Either you check the mental capacity, and if the low risk patient from psychiatric aspect, then you need to discharge this patient. But if a high risk of psychiatric aspects and patient refuse to admission, then you do a compulsory admission under the Mental Health Act. Okay? So they want to check you how you communicate with the patient. So let's,
for example,
yes, yeah.
Just if I am asking patient, for example, for many patient, and while I am asking, he's not answering my questions that related to my questions. Shall I go for next question immediately?
Yes, don't waste time. For London,
okay.
for London died, I don't think so. I had to encounter any patient in any station who doesn't speak. All of them were speaking fluently, very, very clearly, and they were really nice. Yeah, I didn't have any problem with them, and I'm sure that you will not have problem either, because Mrcem is very professional exam. Unless the patient is not very, I would say, if patient is non-native and his or her English is not really good, maybe you can encounter in Malaysia, or maybe you can encounter in India, but I don't think so in the UK. Okay, so guys, and now you see this is a lot to swallow and a lot to focus. So I want to ask you guys, do you want to go for the practice, the role play today, or you want to go for tomorrow? It's up to you. If you think you want to follow this approach, then you can join me. You can go for tomorrow. If you have another approach, you think you have better approach and you're ready, so you can go today, no problem. So I want you do a role play nice, and I don't want. I believe that if I run a role play now, maybe you don't go exactly, or even you run the station very wrong. So I don't want you to do that. So if you're sure, so let's do it tomorrow. We will have 5 stations only. Okay, I want to show you first station, and then I will see who wants to do tomorrow, or how many people are agreed to do it today. So let's see. This is Mr. Ryan, 50 years old, who is worried about him. Mr. Ryan is not been answering phone. This station can come up this way. And take a brief history, perform a mental state examination, explain your finding to examiner. Now you see you have 3 points to do. Take a brief history, perform a mental state examination, explain your finding to examiner. They don't ask you to give the clinical decision reasoning, but if you have time, okay, give the better. Okay, give clinical decision reasoning would be better, but this is the main task. So this likely patient will go to the depression. When you come up to the station, you will know it. Another station we are having, Miss Jane was admitted to observation ward after iron overdose 2 hours ago. Her investigation are all normal. Your colleague wants to give her antidote, but she refused. She would like to go home. So first you will go for the mental state examination. You will see if she is low risk or high risk. Okay. If low risk, then you will go for the medical treatment for antidote. If she refused to go for antidote, then you will assess the mental capacity. If she does have, then you destroy this patient. Clear? But if you found that she's a high risk, she harmed herself and she wants to do again, in that case, she needs admission. Another station I want to show you, this is about the paracetamol. Okay? You have been asked to review her and decide if she's safe to destroy. The same will like iron overdose, but this is a little bit different. Maybe she will agree for an acetylcysteine. Maybe she's high risk, maybe she's low risk. It depends. So it depends on me how I make this station for you. Okay, the next station we have is about unusual behavior. So this can goes to the psychosis. This station with anxiety. Okay, I edit. This is directly come up, but here they want to test you how you approach the patient. Here is Miss Chloe, is a 50-year-old again, and worried about behavior. It can be different ways. Again, you need to perform mental state examination, explain your finding. The last station is about alcohol. So these all stations are important. It's not necessarily you will have 100% like that, but you can have a little different. Overall, the station runs the way I mentioned you. If you run the station the way I mentioned to you in just now, if you run the station that way, I'm sure you will get around 8 to 9 score. Yes, there is one thing I missed, is the forensic history. Yeah, you can edit forensic history if you think. Okay. Yeah, I just missed it quickly. Okay, so forensic history you can edit, but it's not very important. As I said, the important for the exam is two things: mental state examination, your presenting finding to the examiner. That's very important. In between, if you forget one history or if you forget 1 or 2 points, they will not mark it like you missed anything, because those history you can take in even in other stations, so that's not really a big deal. Important how you do the mental state exam and how do you run the station. Don't just go like, okay, you found the depressed patient. Okay, how can I help you? What have brought you today? Okay, can you tell me more about what's wrong with you? This is wrong way to run station. How's your mood? Okay, how's your mood? This is very, just like you memorize something and you just verbalize it. This is not a way of communication. Communication ways, your tone. For example, a patient is depression patient, she is sad, and you're talking like, how's your mood? Okay, what's wrong with you? This is totally incorrect. You need to run a station like this way. I see there's a lot going on around you. Could you please tell me, very, very in pieces, very low tone, could you please a little bit tell me how's your sleep nowadays? Okay, but very soft sound, very soft, that you mentioned that you are with that patient and you are feeling the same way. You have to show the feeling to the patient, and that you can get good score. Otherwise, you're fail in this station, I'm sure. Not only you, all you guys will fail if you don't follow. But this Osce exam is actually, you need to be a best actor. The best actor you have to be. You need to perform just like a drama, like you're in a movie, that you're performing an activity and you're doing acting, which is not existing in real time. So usually people also said, but I also feel that for the RChem in the ASCII examination, you need to be a good actor. Okay. So guys, tell me, you are ready to do the station now, or you want to do tomorrow?
Tomorrow.
We want to revise this all information. Tomorrow it will be better.
Okay, tomorrow we will come up to, please take with your phone these station photos if you wish, because I don't think so I will upload it today or even tomorrow. So I want you to take the photo now for whatever you need it. You want to take the photo, guys? Or you want I don't think, okay, I will upload it today for you. Okay, I try to upload it for you guys, and you can watch it. And you can watch it, and tomorrow be ready for the stations which we are going to practice. And please, what station I had mentioned, you already saw it. You just need to go how to take the history, and it's not very difficult. Maybe 4 or 5 times if you practice with your friend or here, then I'm sure you will be master of that, and you will never forget it. And make sure that the connector, as I said, communication connector, must use it. Don't communicate like you are reading books, or you are just like reading a lesson. No, don't communicate that way. Communicate in like a real time. For example, in your language, in your communication, communicate with the people, you say, oh, for example, you use a connection the same way you need to communicate in English. Okay. My best wishes with you. We will come up tomorrow at the same time, and we will just do how many stations? 1, 2, 3, 4, 5, 6, 7 stations. We will have 7 stations. So we will practice, and we will finish hopefully within 1 hour. Okay, guys, thank you very much for coming, and have a good day.
Thank you, sir.
Okay, any question you want to ask?
Thank you, sir. Thank you.
Okay, my best wishes with you too. It's already very late for you.
Thank you, doctor.